Monkeypox disease has been grabbing attention of people all over the world recently. Monkeypox is a viral zoonosis, which means it has been transmitted to humans from animals. Now, the symptoms of this disease are similar to smallpox, which was eradicated from all over the world in 1980. But thankfully, the symptoms of monkeypox are less severe than smallpox. Recently, on 23rd of July 2022, World Health Organization declared the outbreak of monkeypox as public health emergency of international concern. Centers of Disease Control and Prevention, that is CDC, have also recently released certain guidelines about the management of the disease. I have briefly summarized these recent changes over here. Let's stay updated with the recent guidelines.
Monkeypox was first identified in humans in 1970 in Democratic Republic of Congo. Since then, most cases have been restricted to African countries, sometimes spreading to other countries of the world. Monkeypox virus is an enveloped, double-stranded DNA virus that belongs to Poxviridae family, which are characterized by large brick-shaped viruses. Its subfamily is Cordopoxviridae, which is further subdivided into 6 genera. Our concerned virus belongs to Orthopox virus genus. Monkeypox virus is not the only virus in this genus, but viruses like cowpox, camelpox, rabbitpox, and also the eradicated smallpox virus and its close relation vaccinia virus all belong to the same genus. There are 2 distinct genetic clades of monkeypox virus, Congo Basin clade or Central African clade, which is now called as clade 1. It causes more severe disease, and the West African clade, which is now called clade 2. It is further subdivided into 2A and 2B subclades. The later is the one which is responsible for this year's global outbreak. Since early May 2022, cases of monkeypox have been identified all over the world. Confirmation of even one case is considered as an outbreak. So, how is the disease being transmitted after all? Though the scientists are still researching several facts related to transmission, but it is now accepted that the virus can spread to anyone through close personal contact, skin to skin contact, like direct contact with monkeypox rash, scabs, body fluids from a person with monkeypox, touching the patient's objects, fabrics, contact with respiratory secretions. The incubation period of the disease is usually 3 to 17 days, but it can be up to 21 days long. The illness can be associated with fever and chills. There can be lymphadenopathy, which actually helps to differentiate it from chickenpox, measles, syphilis, and other close differentials. There can be malaise and myalgia, which all of these symptoms can be before or after the appearance of the rash. But all the cases do not have these symptoms. The rectal symptoms like bloody stool, rectal pain, and bleeding have frequently been reported in the current outbreak. There can also be cough, sore throat, and nasal congestions. But the characteristic feature of the disease is a rash, which may be single or multiple, often in genital and anorectal area. It can also be on hands, feet, chest, or mouth. Lesions are firm or rubbery, well circumscribed, deep-seated, and often develop umbilication, which is the central dot on top of the lesion. The lesion progresses to different stages: macular, papular, vesicular to pustular, and then finally scabbing over. A suspect case is defined as a patient with a new characteristic rash or has a high clinical suspicion and meets epidemiological criteria, which includes within the last 21 days coming in contact with a confirmed case of monkeypox or having intimate contact with individuals in a social network experiencing this disease, or having traveled to a location where monkeypox is endemic or had contact with African endemic animal or their products. Case is confirmed only after demonstration of the monkeypox virus DNA by polymerase chain reaction or next generation sequencing or isolation of the virus in culture from clinical specimen. Total duration of the disease is usually 2 to 4 weeks, after which the patient gets better. Disease could complicate rarely, leading to encephalitis, cellulitis, pneumonia, sepsis, abscess, airway obstruction due to lymphadenopathy, keratitis, or corneal scarring. Case fatality ratio in this outbreak has been 3 to 6%. Immunocompromised patients and children are at higher risk. Since the disease is mostly mild and self-limiting, CDC suggests home isolation for the duration of illness, which is 2 to 4 weeks. Exposed people shall be monitored for signs and symptoms for 21 days from the day of exposure. Treatment, which is usually not required due to self-limiting nature of the disease, can be considered for people with severe disease or complications requiring admission, like immunocompromised patients, children less than 8 years, patients with skin diseases like atopic dermatitis, eczema, burns, etc., or pregnant and breastfeeding females, people with complications like secondary bacterial skin infections and other comorbidities, or people with lesions in eyes, mouth, genitalia, where infection might constitute a special hazard. Currently, there are actually no treatment approved specifically for monkeypox. Antivirals against smallpox may prove beneficial against monkeypox. Tecovirimat is FDA-approved drug for treatment of smallpox in both children and adults, although its effectiveness against monkeypox is unknown, but it has been shown to be effective against orthopox virus infections in animal studies. Vaccinia immunoglobulin intravenous is licensed by FDA for complications due to Vaccinia vaccination and has unknown, if any, effectiveness against monkeypox. Cidofovir is approved by FDA for treatment of cytomegalovirus retinitis in acquired immunodeficiency syndrome patients, and its effectiveness is also unknown in monkeypox, but in vitro studies and animal studies have shown it to be effective against orthopox viruses. Brincidofovir, which is approved by FDA for smallpox, also has a similar story as cidofovir as far as effectiveness in monkeypox is concerned. Currently, CDC recommends vaccination for people who have been exposed to monkeypox and people who may be more likely to get monkeypox, like lab workers handling orthopox virus testing and healthcare workers concerned with the virus. Jynneos is the preferred vaccine that these people can take, and it is given as a 2 doses subcutaneously 4 weeks apart. Immunity comes after 2 weeks of the second dose. Alternate regimen involving intradermal route is also authorized for emergency use. It is a live attenuated, non-replicating smallpox and monkeypox vaccine. Another option is ACAM 2000, which is replication competent live vaccinia virus and is given as single dose percutaneously using bifurcated needle, and immunity is expected within 4 weeks. These vaccines can also be used for post-exposure prophylaxis, ideally within 4 days of exposure. If given between 4 to 14 days, vaccination may be less effective but still have some benefits. This summarizes the current recommendations for the disease.
So I hope this was informative and useful. Thank you.